for the first video, we're gonna talk about the language of cardiology, and the first thing we're gonna talk about is rate and rhythm. Normal conduction of the heart goes from the SA node, pauses in the AV node, goes to the bundle of His, and then dissipates into the Purkinje fibers. So a lot of the hearts that we deal with in the CTICU are not normal hearts. They've had structural heart disease to begin with, and then they've just had high-risk surgery. So what we want to know in terms of these patients is A, where's the pacemaker? So is it in the SA node? Do they have a complete heart block? Do they have an AV junctional rhythm? We want to know where the pacemaker starts. Second thing is, what is the rhythm? Is it a tachyarrhythmia? Is it a bradyarrhythmia? That's going to determine what we do next. And number three is, how is the patient? So are they symptomatic or are they asymptomatic? And this is important because asymptomatic patients we can usually talk to consultants about, whereas symptomatic patients we have to run to the bedside and do something about it immediately. So our goal is to have sinus rhythm at a rate that provides appropriate cardiac output, and sinus rhythm is the best for the heart. It generally does not cause additional structural heart disease, so we prefer that if at all possible. So in a quick example is, let's say we have a patient who has severe AS, just had a surgical AVR, putting in the valve, temporarily damaged the conduction system. Now they're at a junctional rhythm and at 50, where their previous was sinus at 70. Cardiac index is low, and we'll talk about what that is further in the talk. And so what we're going to do for this guy is we're going to pace him at 80 to maintain cardiac index while his conduction system recovers after surgery. So the next topic we're going to talk about is preload. And preload is a concept, and it exists only in the minds of physicians. And what this is the volume available for diastolic filling. And this can't be fully known. What we can measure, though, is the filling pressures of both of the ventricles. However, depending on the patient's unique physiology, two different filling pressures, or I should say this, two of the same filling pressures in different patients can yield two very different clinical pictures. So that's why I kind of wrote this formula: preload equals filling pressure plus patient factors, and I wrote down different filling pressures and patient factors for both the right and the left ventricle. Just trying to hit home this idea that cardiology and cardiac surgical patients tend to be very complicated, and knowing one or two numbers generally does not give you a good idea of what's going on. You need to know their underlying pathology, what surgery that they had, and then what post-op issues are they running into. So it's kind of putting together a bigger picture. And so the goal is to have enough preload to maintain cardiac output while avoiding fluid backup and chamber dilation. Right? So we don't want too much preload either. Too little or too much are both bad things. And for the right ventricle, you're going to measure a CVP. For the left ventricle, you're going to measure the pulmonary artery wedge pressure, which is a surrogate for left atrial pressure. And an example of using this for a patient is, let's say we have that same AVR patient. The conduction system's now recovered. He is now hypotensive. CVP is 2. His IVC is a collapsible. So I'm going to guess this guy doesn't have enough preload, and I'm going to give him a 1 liter LR bolus. So you'll notice that the CVP is just one portion of his clinical picture. And you have to kind of know what's going on to have an accurate diagnosis and to go down the proper treatment route. let's move on to the third topic, which is going to be contractility. There you go. And contractility is also a concept that it exists only in the minds of physicians. And the definition of this is the heart's intrinsic pumping power. And this, again, can't be fully known, but it can be estimated by labs and echocardiography. And I put down the four most commonly used values. We'll just go over those very, very quickly. They're going to be explained more in further talks. The first one is SVO2, or mixed venous oxygen saturation, and the normal values are between 50 and 70%. We're going to go over more of how that's measured and what that means in the next talk. Cardiac index, the same. And normals between 2.5 and 4, and less than 2 is generally incompatible with life. We're going to go over more of that in the next talk. Left ventricular ejection fraction is probably the most well-known of the four, and a normal EF is between 50 and 70. Anything less than 30 is considered severe dysfunction. The fourth one, which is probably the least known, is called TAPSE, which stands for tricuspid annular plane systolic excursion. And what that is you use an echocardiography probe to get an apical four-chamber view, and you measure the distance that the free wall tricuspid annulus moves between the base and the apex of the heart during systole. A normal heart will move at least 1.7 centimeters. Anything less than 1 is generally incompatible with life. So taking all these values into account, just because you have a normal value doesn't mean you have a normally functioning heart. You have to kind of know about the patient's underlying pathology, know what surgery that they had, and then understand what challenges that they face post-op. So I just put this little formula of contractility equals anatomy plus drugs, and what that means is that you have to know the patient's underlying issues. So if they have hypertrophy, what kind do they have? And do they have any diastolic dysfunction? As these are going to determine whether inotropes even work, and also if their EF measurements are accurate. And B, you're going to also look at what kind of drugs that they're on. So are they on inotropes? Do they have enough calcium? And are they on any anti-arrhythmic meds? This is going to kind of tell you what is the overall pumping power of the heart, not just looking EF of 50% and saying, oh, that looks great. But we want to know how big is the ventricle, what is their underlying pathology, do they have diastolic dysfunction. Knowing all of these things are gonna give you a more accurate clinical picture and lead to better decisions. So the goal of this obviously is to have enough contractility to maintain cardiac output while avoiding arrhythmias, hypertension, and hyperdynamic circulation. All of those things are harmful both to the heart and to the rest of the body. So a quick example of this is that we'll have that same AVR patient. Let's say they're on their connection system is fixed, they're on epi at 1, now they're having PVCs, their EF is greater than 70%, but we're going to assume they have a hyperdynamic circulation, and we could turn off the epinephrine drip. And the last topic we're going to talk about is afterload. And what that is is it's also a concept that exists in the minds of physicians, and it is the pressure that the heart pumps against. And so again, this again, it can't be fully known, but it's generally estimated by a non-invasive blood pressure measurements or the PA a catheter, or yes, you could also use an arterial line. And there's kind of two things that you have to keep in mind, is that the blood vessels themselves have an intrinsic pressure. So like a patient who's, say, has chronic hypertension is going to have a higher baseline SVR than someone who doesn't. However, when you're in the ICU, these baseline hemodynamic factors are superimposed over patient factors such as delirium, hypercapnia, opioid overdose, pain, and so all these things can change hemodynamic principles or hemodynamic values temporarily. And in the ICU, it's kind of this game of, is this a patient factor, or am I actually treating the baseline disorder of the blood vessels? So it's just something to think about whenever you see really low blood pressure or really high blood pressure. Always think of like, what is the underlying problem? Is it a patient factor that I need to deal with, or is this a hemodynamic property of the actual blood vessels themselves? And it's like very simply, the goal is enough blood pressure to perfuse organs. We don't want to have hypotension because the patient will go into shock, and we don't want hypertension because that will cause hypertensive cardiovascular disease. And a quick example of this is we'll have that same AVR patient whose conduction system has recovered. They are volume resuscitated. They're off the epinephrine drip, and their blood pressure is still 190 over 100. And in this case, what's probably going on, let's say the patient's not agitated, they're extubated, they're not in any pain. There are no patient factors for us to deal with. And what's probably going on here is that when the aortic valve is replaced, a hyperdynamic left ventricle takes a little bit of time to get used to it, because it's used to pumping against a very stenotic valve. So sometimes you have to just give some nicardipine to lower the SVR, while the left ventricle adapts to the new aortic valve that usually lasts 1 to 2 days and it goes away on its own.